Many of my patients, particularly those over 60, come into my office with a similar list of complaints: persistent stiffness in the hips, an aching lower back that never seems to resolve, and knees that groan with every step. For decades, we have been taught to blame one thing: age. But what if the primary culprit isn't the number of years you've lived, but rather the object you've been sitting on? The modern chair, in many ways, is a cast. It holds our body in a fixed position, and over time, our body adapts to that lack of movement. Our hips, which are designed to move through a wide range, become locked. Our ankles, designed for flexion, become rigid. This immobility is at the root of so much chronic pain. You may have seen a video circulating, as I have, of an individual who has been squatting in a deep resting squat every single day for years. The claims are remarkable: that this simple act opened up their hips, mobilized their ankles, fixed their knee issues, decompressed their spine, and even improved their digestion. As a physician, it is my responsibility to look at claims like this with a critical, evidence-based eye. Is this a miracle cure? Or is it a fast track to a joint injury? The truth, as it so often is, lies in the middle. The practice itself is not a miracle. It is a fundamental human movement pattern that we have simply forgotten. But the process of reclaiming it must be done with medical understanding. The video outlines a 100-day challenge, and it begins with a very honest assessment of day 1. It's called The Awakening, and for good reason. The speaker notes that everything will hurt, that the position will not feel natural, and that your ankles, knees, and back will scream. This is perhaps the most accurate part. This initial pain is not a sign of damage. It is a sign of disuse. When you sit in a chair, your hip flexors, the muscles at the front of your hip, are in a shortened position. Your calf muscles and Achilles tendons are also shortened. When you attempt a deep squat, you are asking these tissues to lengthen to a degree they haven't experienced in years. The scream is your nervous system sending a powerful threat signal, trying to protect you from a range of motion it no longer recognizes as safe. The advice given for this first day is medically sound. First, elevate your heels. You can use a small book or a rolled-up towel. What this does, biomechanically, is reduce the extreme demand on your ankle flexibility, specifically what we call dorsiflexion. This modification allows you to sit deeper without your ankles being the limiting factor. Second, hold on to a support. This could be a countertop, a sturdy doorknob, or a pole. This is not cheating. It is essential. It allows you to unload your joints. You can control exactly how much of your body weight is going into your knees and hips, allowing you to gently explore the position without overloading tissues that are not prepared for it. The goal for this first day is not duration. It is accumulation. A few 30-second holds scattered throughout the day is all you need. You are reintroducing your body to a movement, not trying to master it. This is a conversation, not an argument, with your body. After you navigate that initial shock of the first day, the video describes days 2 and 3 as the resistance phase. This is a psychologically critical period. The soreness from day 1 has set in, and your body continues to fight the new stimulus. As the speaker notes, you will question whether this is safe, whether you are causing more injury. This is where, as a doctor, I must make a vital distinction. There is a profound difference between the dull ache of muscle soreness, what we call DOMS, or delayed onset muscle soreness, and true joint pain. Muscle soreness is a sign of adaptation. It is normal. But if you feel a sharp, stabbing, or radiating pain, particularly in the joint itself, that is a stop sign. That is your body telling you to stop, reassess, and perhaps consult a professional. You must never push through true joint pain. During this phase, the goal is to gently increase the accumulated time, perhaps to 5 or 7 minutes total throughout the entire day. The tips provided: squatting while brushing your teeth, squatting while watching television, are excellent. I refer to these as movement snacks. Instead of sitting on the couch to watch the news, perhaps try to squat for the first 2 minutes of the program, using your supports. The key is frequency. Our joints thrive on frequent, low-load movement. This is how they receive nutrition. Your cartilage has no direct blood supply. It gets its nutrients from the synovial fluid in the joint. Movement, the act of compressing and releasing the joint, is what acts as a pump, pushing old fluid out and drawing new, nutrient-rich fluid in. Infrequent, all-or-nothing exercise is far less effective than these small, consistent snacks of movement. By day 7, the video claims a shift begins. This is not magic. This is physiology. Your nervous system is beginning to downregulate its threat response. It's learning that this position is, in fact, safe. The tissues themselves are becoming more pliable. You'll notice you can squat a little lower, and you may rely less on your heel support or your hand support. The most telling claim is that you start to crave squatting instead of sitting. This may sound strange, but it's a sign that your body is recognizing its natural, optimal resting position. Sitting in a chair cuts off circulation and puts pressure on your ischial tuberosities, your sit bones. The deep squat, by contrast, is an active resting position that keeps the joints of the lower body engaged and lubricated. The claim that it fixes knee issues is a strong one, but it has a basis in science. For many types of patellofemoral kneecap pain, the issue is poor tracking of the kneecap. A controlled supported squat can help strengthen the muscles that stabilize it, improving that tracking over time. However, if you have advanced osteoarthritis or a significant meniscal tear, this movement could be contraindicated. As you progress past that first week, the program introduces a new goal: accumulating 30 minutes per day by day 14. I want to be clear about this. As your physician, I am less concerned with a stopwatch. 30 minutes is an arbitrary number. The principle, however, is sound. You are now moving from brief introductions to making this a substantial part of your day. But again, this must be accumulated. One single 30-minute squat hold is an advanced athletic feat. 30 one-minute squats spread throughout your day is a sustainable therapeutic habit. The key is to continue integrating it. When you would normally bend over from your waist to pick something up, try a squat instead. When you're waiting for the kettle to boil, squat. The video is correct to call day 30 the embodiment phase. This is where the biomechanical changes meet psychological habituation. It no longer feels like an exercise you have to do. It becomes a position you choose to be in. The speaker mentions squatting everywhere, and while you may not squat at the bus station, you will find yourself naturally dropping into a squat at home. The claim about improved digestion is also mechanically plausible. The deep squat position physically compresses the abdomen. Your thighs put gentle pressure on your ascending and descending colon, which can stimulate peristalsis, the muscular wave that moves waste through your digestive tract. It also aligns the rectum in a way that is far more anatomically correct for defecation than a modern toilet. Finally, the video describes days 50 to 100 as the lifestyle phase, where the transformation becomes permanent. This is the ultimate goal of preventative medicine. You have reintegrated a fundamental movement pattern so thoroughly that it becomes an automatic part of your movement vocabulary. The claims of complete freedom are aspirational, but the improvement in mobility is real. The claim that the squat decompresses the spine is interesting. The deep squat position brings the lumbar spine into gentle flexion. For individuals with spinal stenosis or facet joint syndrome, this gentle opening of the posterior elements of the spine can feel incredibly relieving, like a form of self-traction. However, and this is my most important medical warning, that same lumbar flexion can be extremely dangerous for someone with an acute posterior disc herniation. The video's philosophy that you are not too old and you are not too injured is a powerful motivator, but it is not medically precise. There are people who should be extremely cautious. If you have had a recent hip or knee replacement, you must clear this with your surgeon. If you have severe bone-on-bone osteoarthritis, an unloaded supported squat may be helpful, but a full deep squat may be impossible and damaging. If you have severe balance issues, the risk of a fall is high. This is a powerful tool, but it is not a panacea. It must be approached with respect, intelligence, and patience, starting with supports, listening to your body, and never ever pushing through true joint pain.